Good afternoon. So yeah, as Christine said, I'm a researcher from Edinburgh, and I've had the privilege of contributing to Roadmap over the last year and a half or so. The work that we've done together with all of our collaborators is all about defining the outcomes of Alzheimer's disease that matter most to the people affected by it. And today I'm going to tell you a little bit about the scope of the work that we've done and the methods we used before handing over to people who can tell you the more interesting stuff, which was about some of the results that we found. So as you all know, this is a huge issue, and Roadmap is aiming to tackle the need for more information around Alzheimer's disease in a particular sort of way. And that is to identify which are the most important outcomes of the disease from the different perspectives of people who live with it, who care for people who live with it, and who treat people, who research the condition. But then beyond that, we want to actually enable access to data on those specific outcomes and also guide on the use of real-world evidence. As you might have heard earlier from John Gallagher, real-world evidence there's lots of it, but it might not necessarily be in the format that we need or necessarily contain the information that we need. So Roadmap is tackling all the sort of challenges around identifying and developing disease-modifying treatments for Alzheimer's disease by enabling access to information on more relevant information. We often find that trials are designed using the definition, clinical definition of the disease as endpoints. So when we talk about outcomes in trials, those outcomes might be just specific health aspects of the disease. We've started this project with no preconceptions of which outcomes matter. It's more than just health. It's all the ways that the disease can impact on people's lives. So that's more than health. That's more than memory. It's more than cognitive ability. It's also about practical and personal issues, the way people live their lives, ability to perform daily activities, and also their quality of life. It's aspects of how they interact in their social lives, in their community, impact on the supporter and families, access to information and services, things like cost, the requirement to buy drugs, loss of income due to work. So all of these are potential outcomes of this disease. And as I said, we started this project with an open mind as to which outcomes people would say were most important. We didn't want to start with preconceived ideas. So Roadmap as a program is divided up into these 8 work packages, and we are talking today about work package 2, which is all about outcome definition. All of them have worked over a 2-year timeline, which might seem like a long time, but it really isn't if you have a lot of work to do, which all of us have. You can see that the program goes across very broad areas, including modelling the disease, health economics, the regulatory environment. But again, we today are just going to talk about these outcomes of Alzheimer's disease. The funding has come from the European Union, from pharmaceutical companies, and the Innovative Medicines Initiative. The work that we've done, again, just to give you an indication of the breadth of this program, in work package 2, this pink line here, these are the 5 sort of main projects that we've undertaken. Most of the work you're going to hear about today was about bringing together that list in the middle, the priority, real-world evidence, relevant outcomes of Alzheimer's disease. So a lot of the work that we've done has fed into that. And although there were these 5 separate projects, really that list of priority outcomes is sort of main output of our work program. So as you've heard, I think, earlier today as well, there are lots of different organisations involved in this work, and we really couldn't have achieved it without the breadth of input. So that ranged from non-governmental organisations, academic institutions, and pharmaceutical industry. This is the first time I've ever worked on a programme like this. I've really got a background in the National Health Service in the UK and academic institutions, but it's been a real sort of pleasure to work with Roche. We've sort of found a shared interest in really good quality research, really high standards across the board. And that's what we've aimed to do here, is to sort of set up this platform of potential research and potential work into disease-modifying treatments in the future with a really good, robust grounding in research methods. I'm going to tell you a little bit more about those. So the first stage for an awful lot of research is to find out what's already been done. It's really important to avoid duplicating effort, and that was no different here. So we started with, depending on the scope of the questions we were trying to ask, either a pragmatic literature review or a systematic one. I'll tell you a little bit more about those in a second, why we choose one over the other. Once you review what has already been published, what you can get your hands on, it's necessary then to design methods for gathering new data to fill in the gaps and answer questions that the literature can't give you information on. And again, that has to be designed in terms of what's realistic, what resources do you have what resources do you have in order to gather that, what do you really need? And as you can see, just those two types of research approaches involve several different projects. Group consultations, individual interviews, and surveys. And you'll hear a little bit more about all of those as we go through. The final step for this was to bring all of it together. And this involved sort of mixed methods analysis. Each type of data gathering exercise requires its own appropriate analysis. With all of the partners that you saw, of course, we have to establish consensus that everybody agrees with the findings that we established. And we used that enormous wealth of expertise to place all of this in a real world context so that it really mattered, it really meant something, and it wasn't just a sort of researcher's perspective. So as I mentioned, sometimes you need to do a pragmatic literature review, which is a quick method of pulling together information on a question, which can be done at the start of a project. We use them to set the scene on the outcomes of Alzheimer's disease that were already out there in the literature. This helped us then define terms for the systematic review, which was a more sort of robust piece of work that we can refer to and pass on to all the other work packages. That was a really important start to the project. There was also a second pragmatic review about the outcomes used by health technology assessment organisations, and one of our colleagues, Annette Bauer, will present on that later in the conference. Tomorrow, there we go. And that was, again, really useful, sort of quick look, relatively quick look at how decisions are made around sort of funding of treatments. The systematic review, which was one of the main sources of evidence for that stakeholder prioritised list of outcomes, took up quite a lot of my time on this project. And really what that is a very sort of, as you would guess, systematic, comprehensive and unbiased collation of all available information on a particular question. That question was, what outcomes matter to people with Alzheimer's disease, their supporters and healthcare professionals? So that gives us a really robust and objective platform for our list of outcomes. And this has complemented all the other work. It's been the basis of quite a lot of what we've done since then. And the way it works is you start with, you cast the net out across the medical databases and other sources of information. We started out with just under 4,000 articles. These are then filtered down. As a team, we did this sort of blind to each other to ensure, again, that it's unbiased and that the right information gets through. We ended up with 119 studies that we reviewed in full text. You check those for quality and, again, relevance to the question to make sure that only the best quality evidence gets through. That means that you can report your findings with confidence that the best quality evidence is going to give you the right answer to the question. And we ended up with 34 studies there, partly, again, supplemented by other experts being able to fill in some gaps of papers that slipped through the net. So that 34 papers was the starting point of our evidence base for this systematic review. So then in terms of gathering new data, these broadly fall into two types within Work Package 2. Qualitative data, which is about the narratives and descriptions. These are generally done in interviews or focus groups, which are transcribed. And it's all about the words and feelings. People describe their experiences. So very quite time-consuming, incredibly rich information that you can get from this sort of data. Quantitative data, which we gathered through surveys, is all about numbers and rankings. You know, which outcome do you prefer over another? These data are sort of measured and they're literally ranked. They allow you to go broader. You can get more people involved in your research, but you tend to get a narrower answer. You'll get a yes or no or a preference of one over the other, as opposed to the qualitative data, which can explain how people feel about something, what they mean by it when they use a certain word. Both of these are incredibly important types of research which went into this process. I won't spend too long on this because you're going to hear more about it from Christophe next, but part of the qualitative data that was gathered for this around which outcomes mattered and what they meant to people was gathered through the European Working Group. And as I said, Christophe is going to tell you a lot more about that shortly. The surveys that were carried out with professionals, not just healthcare professionals, but people working in other professional fields in dementia, people with dementia and their supporters. And this evidence allowed something quite unique, which I said before, which was direct comparison of different outcomes, which ones were more important at different stages of the disease. And we hadn't been able to get that from any of the other evidence we'd gathered so far. The review gave us lots of information from around the world about what people thought was important. The qualitative evidence added a lot more context about what each thing actually meant to people. And then the surveys were used to sort of give us the relative importance of different outcomes. So in order to put all that together, as I say, I've sort of simplified it here because you can imagine all these different projects. They're all sort of started at different times. They all fed into each other. But ultimately, we've sort of tried to bring it together into a fairly straightforward list of the outcomes that matter to people. So as you can see, the literature review outcomes came through the description in each study, either by ranking or by thematic analysis of the words that people used. In the qualitative information, again, outcomes appeared sometimes by how often they appeared or just how consistently they were reported to be important by different participants. And in the quantitative data, it was literally people ranked one outcome over another. All of this was brought together through the analysis methods that I've mentioned. And I just wanted to sort of briefly add a term here that you'll hear a bit more of later. When we use the term outcome, we're talking about a specific focus component of an impact of the disease. And we've grouped these together, and Michael will explain more about this later, into categories. These are just umbrella terms that group outcomes together. So just in case that gets a little bit more confusing later. But we brought all of this evidence together through discussions within the core teams. We had group data synthesis meetings where people came together either over video conference or in person, and ultimately we had to achieve consensus on what this all meant as an entire work package, and I'm incredibly proud of how well everybody came together to make that work. It's not an easy task. And finally, a sort of governance step within Roadmap is added with again, another sort of layer of expertise. We've got the advisory group and the executive committee there to just make sure that what we've said makes sense and that it fits within what Roadmap was aiming to achieve. So just some brief reflections on the work. As I said, it was a 2-year timeline. It was quite a lot to get done in that time. We worked with multiple work packages, as you've seen, most of which had cross-cutting and interlinked work, which was kind of challenging sometimes, particularly with all of the remote working that we had to do. Quite difficult to achieve quick progress when you can't just have a face-to-face conversation with people. And as all researchers do, we all complain at the end that really there's just more that we would like to have done, and lots of unanswered questions that we wish we had more time to address, people that we didn't manage to involve, and yeah, some stakeholder voices that we would have liked to represent which aren't here. But we hope that we've achieved something very robust that will be used to take a lot of this work forward. The opportunities, as I've mentioned, really amazing access to expertise in Alzheimer's disease. This is not my background. I'm an absolute bog standard researcher, analyst, so come to this without the expertise in Alzheimer's disease, but always knew that we had people that could answer difficult questions for us. Pan-European representation, again, a first for me. I've not worked on a programme as large as this, and just an amazing opportunity to connect the people, voices of people with dementia straight into people actually making decisions and designing policy and thinking ahead for how things might change. So as I said, we hope this is a really robust basis for the findings, and that we've put this work in place with the best possible sort of methods behind it to support lots of future research and development. And just final reminder as to what the point of this was. So we identified the priority outcomes of Alzheimer's disease and dementia, and you're going to hear what they actually are shortly. And the next step is that to enable access to that so that research and development can be undertaken actually using this real-world evidence on the outcomes that we can be confident are what matter most to people. And that work has been taken forward by our other colleagues in work packages 3 and 4. And again, there are other sessions on Roadmap if you want to hear more about the next steps. So that's all for me. I'm going to hand over to Christoph, who is going to tell you more about that qualitative work. Thank you very much.
So before doing that,
sorry.
So if there would be, you said that there are, of course, things that we always want to do more. If you would pick one more thing to add to this research, what would that be?
One more thing to add to the research. It would have been good to go broader. Oh. That one. Yeah, not close enough. I think to involve more people with dementia and more supporters. I think the groups that we involved, even in the systematic review, we didn't find any papers that involved people with dementia beyond moderate stages. So that's definitely a missing voice. Also, it always struck me that just by you have to make definitions in the systematic review about what you're looking for. So that meant that we had to use a certain sort of bunch of search terms that definitely missed a lot of people, perhaps former carers, who I think would have a perspective which is different again. So I think there are definitely several groups within the carer and people living with dementia communities that are missed here, unfortunately.
Okay. Thank you. Do we have any questions there before we move on? Yes, one in the front.
Really good to hear your presentation and hear about the work. I just thought I'd let you know that we're also doing a very similar piece of work. We're developing a core outcome set for people with dementia. My name's Siobhan Riley from Lancaster University in the UK, and I'm here with the team. But I just had a very specific question about your systematic review, and you ended up with 34 papers. What were your inclusion criteria for actually getting into it?
So yeah, it was quite specific, and it was something that we debated a long time. So I kind of glossed over it here. We went very specific on Alzheimer's disease and a diagnosis of Alzheimer's disease in the included population. So that massively reduced the number of papers that were relevant. We initially would have liked to include any dementia diagnosis to keep the net broad and to make it as relevant as it was in the other aspects of the work, because there wasn't a similar restriction in the qualitative work and in the surveys. But for the systematic review, we sort of did a pilot study of how many papers we were likely to get, how long it was going to take us to get through them, and we realised that if we were going to publish this within the timescale of Roadmap so that the other work packages could use the information, we needed to cut it right down. So it was people diagnosed with Alzheimer's disease and their carers, and it was quite specifically studies which had elicited their opinions about what mattered. So it wasn't necessarily surveys or consensus studies. It was research that had been done to elicit the views sort of directly from the stakeholder group. So again, that cut down our source material quite substantially.
Thank you. You should also mention that the material is available online. Thank you, Claire.